Sickle cell disease is thought to affect ovarian reserve in women over 30, particularly, and it leads to accelerated decline in ovarian reserve. So in healthy women, we expect to see a decline in ovarian reserve that starts to be more pronounced after age 35 and continues on to until menopause and becomes more acute in those 15 years. In women with sickle cell disease, what we see is that ovarian reserve declines really starting in women's 20s and 30s. And the drop off that we see is much more acute than what we see in women who do not have sickle cell disease. There were two hypotheses for our study. The first was that women with sickle cell anemia, so that's women with hemoglobin SS and hemoglobin S beta 0 thalassemia, forms of sickle cell disease, would have lower ovarian reserve than age and race matched controls. And we also hypothesized that clinical complications of sickle cell anemia, along with treatment with hydroxyurea, would cause further diminishment in ovarian reserve. The biomarker that we used in both controls and women with sickle cell anemia is called anti-Mullerian hormone, which is an established marker of ovarian reserve. We found that women with sickle cell anemia had lower anti-Mullerian hormone, that is lower ovarian reserve, than age and race matched controls. And we found that that was statistically significantly lower in younger women, ages 19 to 25, whereas it was still lower in women ages 25 to 30, but it did not quite reach statistical significance. Among the 16 participants in this study, we identified that 4 had diminished ovarian reserve. Diminished ovarian reserve is a risk factor for infertility in women under 40 years of age. We wanted to understand the differences between women with diminished ovarian reserve and women without diminished ovarian reserve. And we found that women with diminished ovarian reserve were modestly older than those without diminished ovarian reserve by about 3 years. And that those with diminished ovarian reserve were had a higher mean corpuscular volume, which is a proxy measure for taking hydroxyurea treatment. And in a regression analysis controlling for age, we found that that lower anti-Mullerian hormone, which is this marker of ovarian reserve, was associated with taking hydroxyurea. We did not find that there were significant associations with diminished ovarian reserve and clinical complications, except for retinopathy. Only subjects with retinopathy in our study seem to have diminished ovarian reserve. We did find that women with diminished ovarian reserve had less pain than women without diminished ovarian reserve, but this might be expected because they were taking hydroxyurea. This was a pilot study with 16 subjects, and so the way that I think about these results is really that they should be used to inform a conversation that's happening between physicians and patients with sickle cell disease as they're making consequential treatment decisions and also planning their reproductive lives. So it's an NHLBI guideline that we should be talking about reproductive life plans with our patients. And this information that it's possible that fertility declines at a younger age than in the healthy population needs to be provided to patients so that they can make more informed decisions about their reproductive lives. I also think that the definition of infertility in healthy women is that you've been trying to conceive for 12 months if you're under 35 years old, or 6 months if you're over 35 years old. And these age cutoffs for defining infertility may be invalid in women with sickle cell disease. And so having a conversation with women who are pursuing pregnancy about whether they're having success becoming pregnant and having a lower threshold to refer to the infertility doctors may be sensible.